EnComPaSS is a way of providing palliative care in the community that's enabled by technology.
It's about service redesign. It's about service improvement. It's not about replacing services, it's building services, and it's delivering services which quite frankly aren't there at the moment. It came to us from our colleagues in Canada, and it's around enhanced palliative care support services. The technology had been developed some years ago and had been rolled out as initially a paediatric service and then as a palliative care service.
The real challenge in some of the rural areas in Canada, and we're not talking up north, we're talking still near the cities, an hour to 2 hour driving distance makes it really hard to extend services into community. So we looked at how can we leverage the expert nurses that we have that could be geographically disconnected from where the patient actually lives and help provide that service to help patients that would normally only be able to have their final days be either in a very advanced hospice environment, but more than likely in an acute trust, to be able to stay at home. There's quite a bit here, but we're going to really focus on two critical actors in this team environment. So when I'm using the phone, I'm acting as the tech at the bedside with the patient, and when I'm on the big screen here, I'm acting as the nurse. This nurse has got a list on the left here that shows the patients that he's responsible for, that he's actually directing, and legally responsible for these patients. And below we have patients that he may be observing. And we'll take a look at this one patient here. So we have Tanya. This particular patient, there's a question mark, means there's no one at the home yet. We're going to take a look. We can go in and look at, of course, the typical things you would see in an EMR. The background information on the patient. We're going to switch gears for a moment. I'm acting as the tech here. The first thing I'm doing is I'm going to go to my patients. Mrs. Chisholm. So that's the address. And so now that I've arrived, I've got the ability to go in and do quite a bit. So I can go in and send a quick message to my nurse and say, I'm sorry I'm late. Key wasn't under the mat. Now I have some lit up alerts on the right, and so I know there's a series of tasks that are waiting for me there. So the first thing for me to do is to do a check-in. Give a quick summary for the remote nurse, what's happening with the patient. These are fairly basic things, but can be quite important for someone who's working remotely trying to understand what's happening in the home. We're just getting a general sense of the environment and of the patient themselves. Is the family present? Are they awake? Yeah. I might put in, tired. And this is, again, relative to training and how the organization uses this. So regardless of which patient I'm in, I can always see that information's come in on Mrs. Chisholm. We'll take a look at the patient and we'll see what's rolled in. The yellow indicates submissions that are being made that are not necessarily a high priority as far as the document is considered. It's not a red alert. I have the ability to go from monitoring to mentoring, so let's chat. So that's fine. How is the patient's pain? And even though the patient reported their pain was controlled, I was a little concerned they were having some difficulties. And maybe I would send them an instruction to say, why don't you do a pain assessment for me? Those successes gained the interest of academics. So it was an academic bridge from a professor in Canada who is seconded partly to the SHAR here.
I suddenly realised that the system that we've got in Canada is very, very similar to the one we've got here in the UK. It's extremely fragmented and we don't have a continuity of care even within palliative care. And while we've got fantastic specialists and palliative care experts and working through the hospices and through the trusts, we don't have the number of these that are actually required to provide the care in the community over here in the UK.
So where the Yorkshire Number Clerk comes into the story is providing the evidence around the EnComPaSS technology working in this country. We've supported Sensory Technologies to set up their UK office. We've developed a palliative care network of people who are interested in innovation and service improvement. And we've supported a local hospice, St Luke's, to get some funding from the Nursing Technology Fund to be a UK pilot site.
We had a really amazing opportunity to go to Canada and witness the technology being used firsthand, and that was quite an experience. We understood it from both the patient and carer's perspective. We could see it being used by clinicians at the desktop, and we could also see their strategic commissioning bodies using the tools and technology and discussing it. I think one of the things that struck us immediately was Dawn, a tech in Canada. She was using enhanced skills, she was using the technology, but it was giving someone who was very patient-centred and patient-focused the capacity to gather information at quite a high level in a completely unobtrusive way. I think the patient themselves was hard pressed to know that a level of assessment, and we were hard pressed actually to know that level of assessment was going on.
St Luke's is a 20-bedded inpatient centre, but actually that's the tip of the iceberg. The majority of our care is delivered out in the community. At any given time, our community nurses have a caseload of about 300 patients across the whole of the city of Sheffield. I saw the demonstration from Patrick from Sensory Tech of the e-shift model, as it is in Canada, and I could very quickly see how through the act of delegated nursing you could look at transforming your nursing workforce.
What we envision it allowing us to do is to really use our specialist teams in a more effective way. Take our specialist knowledge from the hospice sector, from the specialist palliative care sector, and deliver it more effectively, more cost effectively, more efficiently. We can have a specialist nurse or a consultant, if we need to, in the home when we need them.
Even though it seems like a technological solution, it isn't. And the technology is actually only in supporting the care. It's just transferring the information from the patient care providers through to the remote nurse that we're using. And so it's actually enhancing the model and the way that we're actually delivering healthcare.
Fundamentally, this is a reorganization. It's a change management project. And so the second piece that we bring is global expertise in how to manage that change, how to help align the different clinical organizations and their staff to both be comfortable in lockstep when they go ahead with the model, but as well explore the issues around delegated acts, the legal constraints, the social issues, the liability issues, etc. So we start off with a really solid base to move ahead.
I haven't been a carer, but I've certainly been a patient. I think the benefits are enormous. To be able to come out of hospital perhaps earlier, having spent long periods of time in hospitals, you know, however lovely they are, it's not like being at home. So I think enormous benefit.
What the pilot will show us is where our kind of systems and culture get in the way of delivering that integrated care. And there are many kind of parallel services that we provide where you should be able to transpose EnComPaSS into those. So I think it'll give us a kind of test bed and no service operates in isolation, so inevitably, even in the test bed, although it's a kind of St Luke's base, it's going to involve SGH services and staff. So that will begin to kind of surface those issues that need tackling in terms of the service redesign and the culture. It'll also give us a kind of, it'll be one of those kind of catalysts, won't it, that bring people together, give people a kind of safe space to talk about things and begin to explore the possibilities of what could be rather than what we've got at the moment.
It's challenges around whether you've got the IT infrastructure in place, whether the peripherals talk to each other, whether the nurses are really engaged with the whole concept, that they're part of the evaluation, they feel partners.
I cover the whole of the city, so I can only really geographically see 3 or 4 patients depending where they are in the city. This will allow me to actually, if I've got nurses working at different sides of the city, it will allow us to see far more patients, but with that same sort of ethos of doing that face-to-face, same day.
The idea is that it can be adapted to suit any organisation and their care pathway. They don't have to adapt to suit EnComPaSS. EnComPaSS is flexible enough to work around and build within their care pathways.
My vision would be that actually once we've really understood and explored some of the challenges and barriers to implementation in the palliative care world, we'll move on to look to people with chronic disease. That will be our next step, I think.
initially, as I thought, perhaps this was a sort of distance thing. It isn't. You still see a person. You still see the person. You still build up a relationship with someone that comes into your home. So I think huge advantage for both patient and carer.